Thank you guys for having me. Just a quick introduction about myself. I'm at Children's Hospital Philadelphia. I'm trained in pediatrics and then sports medicine, so I do not claim to be a pain management specialist in the kind of common sense of the term, but I work really closely with our orthopedic surgery partners to try to help overall treat our patients and trying to get to the best possible treatment options and lifestyle. So again, I was asked to give this talk. One of my patients, mom is in the room right now, and Anne and Alex Arcader, who's one of my partners, we share a lot of patients, and so Alex is in Chile, so hopefully I can step in and speak on some pain management options. So there's a new diagnosis, or I should say definition of pain management that came out in 2020 by the International Association for the Study of Pain. And I really like this definition. It is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So pain is really complex. I think we all in this room can understand that everyone's pain is different, and how do we perceive pain can be multifactorial. And so this definition really helps. It doesn't have to be a definite damage, but it has to be a potential or perceived opinion that there is pain. Like I said, it's always a personal experience, and your experience can vary depending on who you are, the psychological, social factors that are happening around your life as well. It's not just the perception of pain, but it can also be inflammatory, neuropathic, non-inflammatory, or non-neuropathic. So I think it's really hard to say where is the pain coming from, and it's not just I touch something and I feel that pain sensation because I burned myself. It is the burn happened and then what else goes with it. And you also learn through life experiences. So someone who has experienced pain from a very young age may have a very different perception of pain than someone who's never had any experience with pain in their life and goes through childbirth for the first time. Lucky them. And everyone's pain scale, like I said, is personal. So we really have to make sure that we don't judge someone for saying their pain is a 3 out of 10, whereas someone else's is a 9 out of 10. And you say, well, your pain can't be that bad, it's only a 3. But it's your 3 and it's someone else's 9. And you might, some people like to say that the 0 to 10 pain scale is terrible and their pain is a 15. So again, everyone's pain is personal. And it may be adaptive, and some people it may be helpful over time to have ways that they can deal with this pain, but it can also have adverse effects. And you can express the pain not just by saying you have pain, but through other areas. You may be depressed, you may be anxious, and not be able to verbalize that you have pain, and we have to be aware that pain comes in different flavors. So I found this online, and I just loved it, kind of the good, the bad, and the ugly of pain. So good, it's a protective role, right? We are trying, pain is telling us there's something going on. There's a stimulus, there's a threat, there's something different. But it becomes chronic at times, and then that becomes a disease. And how do we treat the disease, and how do we differentiate the good pain from the bad pain? And this is when it becomes ugly, right? We need to know what's going on in order to have the right treatment plan. And you don't want to have unnecessary surgery, or you don't want to ignore pain and miss something that should have been treated, and you can treat someone's pain that they've been dealing with for years. So when we think about pain and kind of the immediate effects, I think all of you guys are familiar with fight and flight. And so this is more the flight, right? So you have an increased heart rate, increased respiratory rate, you have maybe increased muscle tension, your pupils dilate, you may start to sweat, you have decreased GI motility and elevated glucose levels. This is the classic fight or flight, but that is in the acute phase if you have an acute pain response. But chronically, you can have a lot of changes that happen, and your body can adapt, and you can go into this really bad cycle. And so this was just another kind of diagram I found online talking about the chronic pain cycle, but really we can have things with anxiety, and anxiety can cause pain, and then pain can cause more anxiety, and it's a vicious cycle. There's depression that can happen with it. You can be chronically fatigued, have sleep difficulties, mood swings. We may have reduced strength or decreased stamina. So if you have someone who's saying they're just really tired, they can't get out of bed, it may be depression, it may be that they're in chronic pain and you just they're not able to verbalize it. So I think we have to really be aware of all of these different avenues that can happen with pain. This is something from CHOP, for my hospital. We have a amplified pain syndrome. So this is a different conversation, a different talk altogether. I'm not going to go into AMPS, but sometimes your pain pathway can go out of whack. And we can have pain, but there's actually no true underlying reason for the pain. So is it that we had some sort of stress or some sort of injury, and then all of a sudden the pathway went a little haywire, and you can see, my mouse is here. So you can see there's some abnormal reflex that's happening, and you can have some decreased oxygen, increased acid. So I don't know if anyone's familiar with amplified pain. It's also known as chronic regional pain syndrome or reflex sympathetic, RSD, RND, CRPS, lots of different names. Maybe fibromyalgia is part of this. But basically you can have people who have a leg that is very red or swollen, and they're like, there must be something wrong, and it's actually a abnormal pathway that's happened, and we have to fix the reflexes and treat it differently. So it's a very different way of managing amplified pain versus managing fibrous dysplasia pain or post-operative pain or something else. So I just wanted to highlight that there are lots of different types of pain out there. So what about pain and fibrous dysplasia specifically? So does it get better or worse with age? And the answer is the studies are mixed. So some lesions may undergo age-related changes. This is a 2016 study that said there is less severity of pain as you get older. Wouldn't that be nice, right? We all get better with age. However, what about arthritic changes that can happen? A study about 15 years ago showed that you may have adjacent joints that get too much stress, and then you have arthritic changes. Alice and I were just having a great conversation about runners and with FD. Is it good or is it bad, right? We want everyone to be healthy and active, but are you putting too much stress? If you have a lesion at your proximal femur, are you gonna have arthritic changes at the hip when you're 35 that we might have been able to prevent if we didn't put so much impact through that hip? About 50% of patients may report pain. Not everyone reports pain at their FD site. Most people who report pain have lesions in their lower extremity and ribs versus upper extremity or craniofacial lesions. And pain does not necessarily equal the extent of fibrous dysplasia, and so really important to be aware that you may only have some mild FD, but you actually have severe pain, and those with extensive disease have very mild pain. So again, it's really hard sometimes to say, well, and when you're all in a room together, I think you all can very much respect each other, their disease is very different, and everyone responds very differently to their disease burden. So how do we differentiate pain? Allison's gonna go into more of the intrinsic FD pain, and that's coming up next. But do we evaluate with blood work? Is there some underlying hypophosphatemia? Is there a leg length discrepancy because of FD? Is there an acute or impending fracture? Is there a pathological fracture that might be happening? Is it post-operative? Is there hardware? You've had surgery and now you have hardware pain. Is it, what exactly is going on? Because the treatment is gonna change depending on where the pain is coming from. So a patient that Dr. Arcader and I shared was a 16-year-old cross-country athlete. She was running about 20 miles a week, and she had a known lesion in her proximal femur. She'd been told by other doctors, it's not that big, you're fine, you can keep running. And she'd been having this kind of dull, achy pain for about 2 to 3 years. And she came in and I said, you have stress through that lesion. It's hard to sometimes see on the femur, or on the MRI, but I really think that this is related to your lesion. She went and saw Dr. Arcader. She's had surgery, she's doing great. I actually just looked in her chart, just kind of give full update. She just saw him in June. And she's having a little bit of pain kind of deeper in her groin, which is probably mechanical related because she ran on this lesion for 3 years and now she has a muscular pain that will get better with physical therapy. And so she'll come back to see me if she doesn't, and I think at this point the family is very aware of how to differentiate between the pain. But again, this girl was running for 3 years with pain that she could have potentially have treated 3 years prior, and we just want to be really on top of that. So from a pain assessment, I've been kind of talking about how do we assess this pain. There are lots of different scales, and I think some people love the 0 to 10 scale, some people hate it. In younger kids, we have the FACES scale. I don't think there's a great scale out there that is perfect. Basically, when we think about pain related to, when we ask what does your pain feel like, we typically hear that it's dull, achy pain that worsens with activity and lessens with rest. If there's an acute pain, it might be because you fractured through the lesion. But we can ask about this, and there's something in medicine that we think about the PQRST, or kind of what provokes it, what makes it better, palliative, what's the quality of the pain, the quantity of the pain, where is it, the region, the radiation, does it go anywhere, does it start in your hip and radiate down your leg, what is the severity of it, and how does it happen, what is the timing, is it better in the morning, in the evening? So this can help point us towards different types of what our differential might be. And I like to think about your history is about 90% of the exam. Your exam is fine, we can get x-rays, we can do a physical exam, but really it's you being able to explain what you're feeling because it is your body and you know it best. Obviously, we can get lots of images out there. So once we kind of have an idea of where the pain might be coming from, how do we treat it? And I think there are a lot of different ways to treat it. And unfortunately, when there are a lot of options, that means not one is necessarily the best. So we have pharmacological options and we have non-pharmacological options. Allison's going to talk a lot about the pharmacological options, so I'm going to kind of skip through that really quickly. But I will highlight the alternative kind of injections or options in terms of if you have more anxiety, depression, and you're really in a lot of pain, can you help treat that with an antidepressant or I have anticonvulsants because that's in the category of kind of neuropathic pain or chronic pain, like that gabapentin, also known as Neurontin. You can also try topical if you don't want to be taking oral. There's a great over-the-counter anti-inflammatory Voltaren gel, which is now available, which is great. So you're not taking an oral anti-inflammatory every day. In terms of the non-pharmacologic, this is where I want to spend a little bit more time because I think we don't talk enough about alternative medicine or kind of Western medicine versus Eastern medicine. I think there's a lot of great options, especially for someone who's living with chronic pain, to try to approach this in a multifactorial way. And so we have things like acupuncture, which so many studies are out there that actually show that acupuncture help. And so people are afraid of needles. They don't want it. They're super tiny. They don't draw any blood, and it really can help. So I would encourage people, if they're afraid to, just try it once and see what you think. But I really think that acupuncture is a great alternative, and I should not say alternative, but adjunct to treating chronic pain. Cognitive behavioral therapy with a trained specialist therapist in CBT can really help. I like to say to my patients, whether or not they're someone who has fibrous dysplasia, or I see a lot of hypermobility patients, or anyone who's dealing with chronic pain, these are the cards you were dealt. It stinks, right? Like, no one asked for this. If you have type 1 diabetes and you're checking your glucose every day and you have to take insulin every day, you deal with it, right? But you don't let the disease control you. You try to make the most of it. And if you can find ways to breathe through the pain, if you can distract yourself, in younger kids, either play therapy, laughter therapy, kind of understand where it might be coming from and think through it, it can actually help decrease your pain a lot. Then also sensory or physical options like massage, ice, or heat, deep breathing can really help. TENS unit, they're available online, over the counter, can help sometimes with muscle stimulation, especially if your muscles are getting weak around your lesion. And then things that I tell almost all my patients is lifestyle and exercise. Exercise is critical. That does not mean go run a marathon, right? But what about swimming? What about biking? What about, going and playing golf? Something doesn't need to necessarily be a team sport or an individual sport, but being active. Doing something that gets your heart rate up is so critical to not just your emotional, but your physical well-being. And then also making sure that everything else is in play in terms of your diet, your sleep, making sure we're minimizing any extraneous stressors that may be contributing to your pain. So in terms of interventions, this is more of what I do in my practice. I do ultrasound-guided injections. There are a lot of different ones that I kind of highlighted on the last slide, but we can also do peripheral nerve blocks. Trigger point injections can be really helpful, especially if a muscle is spasming around a lesion. Epidural joint injections if it's more spinal. Radiofrequency ablation if your nerve has really become so hot that you're having a lot of neuropathic nerve pain, you can get that nerve ablated. So in terms of the ultrasound-guided injections and kind of highlighting this other patient story I was saying with hip pain is the patient I saw in the office who was having this deep hip pain, I ended up doing an intra-articular injection or an injection into the hip joint. And you can see on the bottom right here, that's an ultrasound picture with, let me see if I can do this right. This is the acetabulum right here. Hold on, I can't. There we go, right here. And then the femoral head and the femoral neck is right here. And this is the needle right here. So I'm putting medicine right into the intra-articular joint space, and the capsule that's over the hip is right there. And so what we're doing with this is trying to figure out if the pain is coming from inside the hip joint, and I do an exam before the injection and I do an exam after the injection, how much better is the pain immediately with the anesthetic on board. It takes about 5 to 10 minutes for that anesthetic to work. And then if the pain goes away to some degree, it doesn't have to be 100%, but you feel better, and we can have a conversation about whether or not we inject a steroid into the hip joint to also help with chronic pain, potentially can last for about 3 months. that if we are doing that, the steroid's not going to kick in for a couple of days and you might be sore after the injection, but immediately before the soreness kicks in, how much better do you feel? And a lot of times we can actually predict if you're going to do better with surgery for the hip, if that is, or any joint, I should say, if that injection is helpful. And in that situation, she had about 90% relief, and so that was one of the indications for Dr. Arcader to go on and do surgery. So it can be both therapeutic and diagnostic, right? We're trying to figure out the pain generator, but we're also trying to help potentially give pain relief. And from a therapeutic standpoint, if we can make you feel better, and then you can have this as a window of opportunity to do better with physical therapy, wouldn't that be great? We can then do better strengthening around the hip because you can't do the therapy because it hurts too much, but the pain is better, and then you can strengthen the muscles that have gotten weak, then maybe we can actually have this be a great window. Those who cannot take NSAIDs for whatever reason, whether or not they're allergic or they have GI upset or any other reason, it doesn't mix with their other medications. And again, we can do this with or without steroids. Some people are, and there are some side effects to doing corticosteroid into the joints. So from a diagnostic standpoint, I think I already talked a little bit about that exam and does it help immediately and help to guide surgical guidance. I will say that these injections are temporary. They are not something that I want to do on a long-term basis. There are a couple of patients that I have that I share with some of my other surgical partners where we know that he's destined to have a hip replacement when he's 18, but he's 16 and he's trying as long as he can to keep his native hip, but he has a different hip disorder that is going to basically continue to change the shape of his hip, and he knows the hip replacement is in the future. I'm happy to do these injections over a period of time, but if this helps, there has to be a more permanent solution. This isn't something that we want to continue to do because there are side effects to putting steroids into the hip over a long term. So, like I said, I work closely with my surgical partners, also with my working with psychologists and other people. It really is a multidisciplinary approach. Pain is very personal, and what works for one person may not work for another. So either people come into the office and say, well, this worked, we have to do it, or this totally failed, my friend, I don't think it's gonna work. And we have to be very open-minded to having different ways of approaching pain. Thinking about other factors, was there a divorce in the family? Is there a death in the family? Is there something else going on that maybe we need to address and come back to thinking about other reasons for why the pain has suddenly heightened? And trying to differentiate bony pain versus post-op pain versus sports pain versus chronic pain. And advocate for yourself. You know your body better than anyone else, and so if the pain feels different, then that's something that should be really taken seriously. This is from a study from 2022 that just highlighted in FDMAS that a multi-center care pathway actually is better from both reducing pain and improving quality of life. And it's a busy slide, but basically it's saying that if you were a new patient and you presented to a multidisciplinary tertiary care center, you did better. So I just think there's a huge benefit for having a multidisciplinary FDMAS clinic. So in summary, pain in general is good, but it can become maladaptive. We need to differentiate types of pain, and it's very challenging. We need to find strategies that work specifically for the person. Not everyone has the same approach. A multidisciplinary approach is best. And try to not let your life be controlled by pain. Try to make it background noise, but obviously advocate and speak up when it's different. So, thank you.